Chapter 26 is concerned with the male reproductive system and rectum. Starting with anatomy, the penis is attached to the pubic arch by ligaments, and it is made up of three masses of vascular erectile tissue that are bound together by fibrous tissue. And some of the features in the anatomy of the penis: on the dorsal side there's the corpora cavernosa, and then the ventral side has the corpus spongiosum. And then in uncircumcised males you'll also see a foreskin, and then the urethra, of course, where urine comes out, and also semen. The testes they're contained in the scrotum, and then the spermatic cord goes from the testes to the abdomen, and it contains vessels and nerves and the vas deferens, which is where the sperm come from the testes through the vas deferens. The cremaster muscle controls how close the scrotum are to the body, and if it's hot, it will allow the scrotum to descend, to be away from the body. If it's cold, the temperature is cold, then it holds the scrotum near the body in order to maintain a fairly constant temperature. The epididymis is sometimes a site of inflammation. It covers the testes, and sometimes it will be the site where you might have inflammation or infection. Then the inguinal area is directly almost next to the symphysis pubis, and it's the inguinal canal. The external inguinal canal can be palpated. The internal inguinal canal ring cannot be palpated, but the importance of this is that the inguinal canal is a site of hernias, and then the femoral canal, which is just below the inguinal canal, is also a site of hernias. Then the anal canal has two sphincters. The external one is under voluntary control. The internal one is not. And the prostate consists of two lobes that are separated by a median sulcus. So, history of present concern. Maybe the patient comes with a problem of the penis itself, and of course any symptom that they have you'd want to do cold spa on. If they have a pain, is it constant? Is it intermittent? Under what circumstances does it occur? These are going to give you clues as to what might be going on. They might have pain. They might have itching, in which case you would possibly have a problem with lice, or possibly a problem with ringworm, possibly just some dermatitis condition. Maybe they came in with lesions on the penis or genital area, and keep in mind that a painless syphilis, which is probably one of the more serious lesions, is actually painless. They have a painless lesion that goes away, so eventually it goes away, but the disease does not go away. So that can be a deceptive thing. They may come in with a discharge, complaining of a discharge from the penis. which of course would indicate probably be an infection, maybe gonorrhea, maybe some other non-specific urethritis, maybe something else. Maybe they came in with lumps, swelling, or masses in the scrotum, or a dragging feeling in the scrotum, and those would both be suspicious for scrotal cancer, for testicular cancer. Now these terms, note these terms, some complaints about urination, urgency, meaning that you suddenly have an urge to go to the bathroom and you better get there quick. Hesitancy means when you try to start urinating, it doesn't come, it hesitates. I've had students see these terms on a test and they don't understand that they have a specific meaning when they're referring to the urinary system that isn't necessarily exactly the same as the common everyday meaning. That some students have gone wrong on test questions for that. Frequency, of course, that would be like constantly going to the bathroom, maybe every 20-30 minutes. That's the guy that every time he passes a restroom he has to run in. Difficulty starting the stream, that's similar to hesitancy. Then nocturia is when you get up several times in the night to go to urinate. Any urinary problems, one thing to ask would be, are you on any new medications? Because sometimes it could be a problem with medications side effects. Also ask about if they've noticed a change in color, odor, or amount of urine, and if they have any problem with urinary incontinence or with dribbling. Sometimes people will be mostly continent, but they'll dribble afterwards. Then maybe they came in with a problem related to sexual activity. Maybe a change in pattern of sexual activity or desire. Usually that it's decreased. That's usually what they would, or maybe difficulty in attaining or maintaining an erection. Now that could be from a number of causes, physical, psychological, hormonal, aging, a lot of different things can go into that. Pain with ejaculation suggests a bit epididymitis. Remember we said the epididymis can be infected, and that would be a symptom that would be pain with ejaculation. Or maybe they just come in with fertility difficulties. They are with a partner and the partner can't get pregnant, and they don't want to know, well, is the problem me or is it her? Or is it both? Or is it like a combination? Then other things that somebody might come in for, a problem with bowels, and you'd want to ask about, and this would be part of the assessment anyway, their usual bowel pattern. Any problem with diarrhea or constipation, trouble controlling bowels, or a change in color and consistency of the stool. Mucus in the stool, and a large amount of mucus in the stool suggests maybe Crohn's disease, ulcerative colitis, especially if it's bloody. Bulky stools that float. If the stool floats, that indicates there's probably a lot of fat in it, and bulky stools that float are characteristic of problems with the gallbladder, or maybe sometimes the liver too. Pain or itching in the rectal area could be from hemorrhoids or in children from pinworms. So then history, we'd want to ask about prior medical problems, especially in the case of like erectile dysfunction or changes in sexual activity, anything to do with neuropathy or vascular problems like diabetes, hypertension meds. Sometimes the problem could be just that they got a new hypertension medication. And so as you can imagine, if you have a hypertension that doesn't hurt you, doesn't really, it's a dangerous situation for your health, but it's not hurting, and then you take the medication and you get erectile dysfunction, how long are you likely to continue taking that medication? So it's important to address these kind of concerns in order to promote people's compliance. When did they have their last testicular exam by a professional, and do they do self-testicular exams? And also, when did they have their last test for a variety of sexually transmitted diseases like HIV, human papillomavirus, and then HSV is herpes simplex virus, and the rest of those, chlamydia, gonorrhea, trichomoniasis, hepatitis. Hepatitis can be transmitted by sexual transmission. Usually it's not common, but it can be. And then syphilis, of course. Rectal trauma, if they've had any rectal trauma or surgery, any history of hemorrhoids. When did they have the last digital rectal exam? And most of you, most of the males in the class are saying never, but that's because you're young. After about 40, 50, depending on your physician, you'll start getting them. When did you have your last PSA? PSA, routine prostate specific antigen. It's a blood test for prostate cancer. It's no longer recommended in routine screening. But if the physician used their judgment, they may well test it. Family history of either colon, rectal, or prostate cancer. And then lifestyle, questions about lifestyle and health practices. How many sexual partners do you have? And do you use, or do you as a couple use any birth control methods? And what are they if you do use them? What methods do you use? If the patient is satisfied with the current level of sexual activity and functioning, there are some individuals that would always say, no, I want more. But, concerns about fertility, whether concerns about wanting less fertility or more fertility. And do they have an intimate partner that they consider their significant other? Or do they have multiple partners and not have anybody that's particularly a significant other? Then any fears related to sex. And then another question, are you comfortable communicating with your partner about likes, dislikes, etc.? That goes to how close the relationship is, how healthy it is, that kind of thing. What do you know about sexually transmitted infections and their prevention? And there's a lot of misinformation out there. And so that's an opportunity to do some patient teaching. Exposure to different chemicals and radiation. There are a variety of chemicals that are associated with prostate cancer. And a lot of those are maybe occupational exposures. What kind of typical activity does the person do? Do they do heavy lifting? That would go to risks for hernias. And then do they do testicular self-exams? Or do they use any laxatives, stool softeners, or enemas on a regular basis, or just occasional? How often do they use them? And then do they engage in anal sex, either active or a passive partner in anal sex? That would increase risks for HIV transmission, but also for hemorrhoids, rectal fissures, tears, that kind of thing. Do they take any medications for their prostate? And then diet. High fiber food is good. I mean, that reduces your risk of colon cancer. High saturated fat is bad. That increases your risk for colon cancer. Do you get regular exercise? And any problems that affect your normal activities? So now going to the objective exam, you start with the base of the penis and pubic hair, and you're looking for rashes, for discoloration, for lesions, for any evidence of pubic lice or ringworm, those kind of things. Inspect and palpate the shaft, again for lesions, for tenderness, those kind of problems. And then the foreskin, in some cases the foreskin normally should slide down completely off the glands without a problem, but there's a condition called phimosis where it will not do that, and that can, of course, like that can result in complications, especially if you're trying to catheterize somebody that has a severe phimosis. It becomes difficult or impossible to adequately cleanse the area before doing the catheter. Sometimes you can stretch it using a forceps, but that can be painful too. And then sometimes you get a situation where the foreskin is, if it's tight, you may be able to get it down, and then if it just stays down long, why then the glands can swell up, and you come back an hour later or so, and you find this swollen glands, and there's no way you're going to get that foreskin to come back up over it, and you start panicking and think, oh, what should I do? What can I do? Well, the tip, take a glove, fill it with ice, and put that over the glands, and that will help reduce that swelling, and then maybe 20-30 minutes later you'll be able to get the foreskin back over there. That usually would happen on somebody that's maybe either unconscious or maybe they've got decreased sensation, decreased movement, they're either semi-conscious or unconscious usually when that happens, because somebody that's alert and moving and all that is probably going to tell you, or either pull it up themselves or tell you long before they would get to that point. Then note the location of the urinary meatus. There's epispadias where the meatus is diverted dorsally, or no, dorsally, and a hypospadia where it's diverted ventrally. And so those are fairly common problems. Palpate for urethral discharge. And usually if you have a urethral discharge, you'll also have pain, although sometimes it might be in a person that's fairly unconscious and not able to express their pain. Then turning to the scrotum, note the size, shape, and position of the scrotum. Inspect the scrotal skin, and you'll have to the scrotal skin is rugated, so you'll have to kind of expand it a little bit as you're palpating to get a full view of it. You might find lesions there that you don't see at first glance. Then palpate the scrotal contents, including the spermatic cord. And you may take this opportunity to teach the patient about scrotal self-exams too, if you're testicular self-exams as you're palpating the testicles. If you find a mass in the scrotum, first transilluminate. Then the scrotum does not normally you can detect maybe a hydrocele that way, or then ask the client to lie down and see if that mass disappears or not. Auscultate the mass, because sometimes that mass could be a hernia that has slid down there, and if it has intestinal contents, why then you might hear bowel sounds. And then try to push it up into the abdomen, see if you can. Then you'd inspect for inguinal and palpate for inguinal and femoral hernias, and then palpate for inguinal lymph nodes. Then turning the patient over, look at the perianal area. And also the sacrococcygeal area for any lesions, discolorations, etc. Palpate the anus, and you're going to do a rectal exam. Don't just stab the finger in. Use the tip of the finger, which promotes relaxation, and you have a lot of lubrication. And then you ask the client to bear down like they're having a bowel movement as you slide the finger in, and you palpate note the tone of the sphincter. Ask them to bear down, then ask them to tighten their sphincter once you get your finger in, and note the tone. And then first you palpate the anus and then the rectum, and then you turn the finger back around to where it's facing ventrally, where it's facing upward, and then you can palpate the prostate. Prostate should be rubbery, about the size of an almond, but when you're doing this, you're typically doing it on older men, and so it's probably going to be bigger, and the consistency might be boggier, or it might be hard. A hard prostate suggests cancer, so that's kind of alarming. Then when you pull your finger out, there should be some stool on it, and you can rub that onto a test strip for occult blood, and you can check the stool for occult blood. Risk factors for HIV. There are two primary ones. The two big risk factors for HIV are men who have unprotected sex with men and unprotected anal sex with men, and IV drug abuse, sharing the needles. Those are the two biggest risk factors, but there are a number of other risk factors too. Some HIV is transmitted during the birth process from a mother who's infected to the fetus. And then there are things that will put you at higher risk, like the presence of another sexually transmitted infection. Being uncircumcised for some reason makes it easier to get. And then some cases get transmitted by accidental needle sticks. I have not heard of cases from blood transfusions in the U.S. in a long time. The blood has been screened very well for at least 20 years or more. But when the AIDS was first discovered, blood transfusions were a very common way because there was no way to screen for it at that time. So quite a few people did get AIDS, HIV infection from blood transfusions at that time. Then piercings, particularly like if you go to jail and you have a piercing artist there that offers to do a piercing for you or a tattoo, you might want to think twice about it. And say, how well do you sterilize your equipment? And he tells you, what's that? And you say, okay, no thanks. Infected breast milk. I don't know how much the risk of transmission through infected breast milk is, but it's obviously not as much of a risk as the risk of direct transmission during the childbirth process or blood-to-blood transmission. Then risk factors for prostate cancer: age, increasing age. Then as far as race, African Americans have the highest rate, but then Caucasians and then Asian and Hispanic men have the lowest rate. But strangely, as far as geography, Africa has a lower rate. North America, Europe, Australia, and Caribbean areas have a higher rate. So it's not just the race, it's also a combination of race and lifestyle in those areas. Family history, and then some gene changes. Agent Orange, that was primarily Vietnam veterans that were exposed to that. Alcohol, diet, and various occupational chemicals. Low melatonin levels, and strangely working night shift. So the idea is that the problem is the sleeping during a lighted room in the day. Theoretically, even if you work nights, if you were able to get your room you slept in pitch dark, well, that would theoretically eliminate that increased risk, but I don't think anybody is able to do that. So there are a lot of more diagnoses than this in your textbook. I just selected a few here. Readiness for enhanced health management requests information on birth control. Typically we think, oh, well, that's the woman's responsibility, but wrong. We need to encourage men to step up to the plate too and take responsibility for birth control. Risk for injury related to poor lifting techniques. That could be something that a risk diagnosis. Then there are a number of other risk diagnoses in the textbook as well. Then fear of testicular cancer related to existing risks as evidenced by the client's statement. And then sexual dysfunction related to erectile dysfunction secondary to blood pressure medication, as evidenced by the client's report. So that's it for this chapter. I'll see you at the next lecture. Oh, no, sorry. One more slide. Collaborative problems and referrals. Risk of complications for syphilis. Look at the textbook, and it shows typical syphilis lesions, but remember that the way syphilis works is you get the lesion, and then eventually the lesion goes away, but the disease doesn't. And then it comes back like you're looking like a rash, and then maybe the rash goes away, but then eventually you get neurological degeneration, or you get severe complications many years after this, and meanwhile you've probably infected other people as well. Gonorrhea, risk of complications for gonorrhea. Gonorrhea in the male usually manifests as a kind of dysuria, for one thing. They have extreme pain on urination, and that's caused because their urethra becomes inflamed, and so the urine is very irritating, and so they, every time they urinate, why they have pain. They also have a drip of a large amount of drainage, urethral drainage, and it's probably pus, yellow-green type pus. Then risk of complications for rectal bleeding. Sometimes you may be the first to discover this. Maybe you've got a patient and the patient says, come here, I think you need to look at this, and they've got a toilet full of blood, and it may be something that they didn't come in with. Maybe they may or may not have had it before, so that may be something you discover. And then risk of complications for urinary incontinence. So that's the end of this chapter.